This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Farrah Mateen. I'm a neurologist at Massachusetts General Hospital and co-editor of the Without Borders section of Neurology. Today I'm pleased to interview Teddy Totimeh, consultant neurosurgeon, Accra Medical Center in Ghana, on the recent publication in World Neurosurgery titled Brain Tumor Programs in Asia and Africa, Current Status, Challenges, and Future Perspectives. Thank you for joining us today, Teddy.
Thank you very much.
In your paper, what components did you use to identify and characterize brain tumor programs?
We used 6 what we call pillars or covariates that would be things that we filtered from our own exposure in various brain tumor programs that we had been involved in, either as part of our training or as part of our practice. And then also what, the journal said about brain tumor programs. So we had 6 pillars that we used to be the anchors for any brain tumor program, which would be surgery, oncology, neuropathology, research activity, training and education, and then a financing program for it.
I'm curious, how many people are in your network in terms of the Asia-Africa Neurosurgery Collaborative Group? And then specifically in your paper, how many countries were invited and how many responded?
In the group, we have about 20 people. It's been a very fluid group. It's a WhatsApp group. It's based on WhatsApp. It's virtual meetings that have kept this going. And we had 92 countries that we reached out to. Now, it's important to note that the reaching out for these countries were done through Telegram or WhatsApp, and these were moderated by the various participants of the group. There were 92 countries, and we divided them into 3. So we had group 1, where we had response for neurosurgeons. So this were about 73 countries. And then group 2, where these were countries without neurosurgeons, but we got it from other neuro-related specialties. And then 16, where we didn't have a real response, right?
I'm curious, how many countries have no neurosurgeons?
So we had 16 countries with no neurosurgeons. And these are countries across from Asia and Africa. However, 90% of these countries were in Africa.
How did you categorize brain tumor programs and how did you score them?
We looked at the pillars and we sent out Google Forms based on these pillars, right? And the Google Forms were supposed to get the information back with responses related to these 6 pillars that we had identified. We realized that surgery, oncology, and neuropathology had the highest weighting in terms of influencing the standard of the brain tumor program, whereas research and training and finances did not, key in as much. So we put these together and we had marks that we gave according to the pillars. So the total score one would have would be 14 and the minimum score would be 0. So according to these scores, we're able to subclassify the brain tumor programs into 5. So level 5 would be the brain tumor programs with the highest scores, which would be 13 to 14. And then level 0 would be under 5. According to our scoring system, we had most brain tumor programs being in the level 3 range. So we had 29 countries being in the level 3 range, and then we had 5 countries being in the level 1, and then we had also 7 countries being in the level 5, right? Now, the thing was the standards were not equal in Asia and Africa, whereas you would have 42% of the countries that were assessed being in level 3 for Asia, it was just 25% of the countries that would be in level 3 for Africa. And the other thing was, level 1 was the countries that sort of scored under 5, and it was 0% in Asia and 9% in Africa. Whereas for level 5 countries, which basically are sort of top-notch and have everything, 14% of the centers from Asia were in level 5, and only 4% were in level 5 from Africa.
So if you had to summarize the main study findings, what would you say they are?
Across the low middle income countries, the standard of brain tumor programs is generally low. However, Africa takes the big hit compared to India. Africa takes the highest number of hospitals with no neurosurgeons at all. And the other thing was the key pillars that would define what the quality of a brain tumor program is would be the surgery, oncology, and neuropathology, and which means that creating a brain tumor program is very expertise oriented. It's very high skill related. And the key thing when it comes to going forward and improving the standard of these brain tumor programs is related to education and training. And these are not short-term things, because training these experts takes a long time. So we sort of had long-term interventions that we thought would be important, and then short-term. So for the short-term, we thought that the concept of training would be with centers in low middle income countries getting together with centers in high income countries to sort of fast track the transfer of expertise. And then also really leveraging technology. Now with webinar training, Internet of Things, we can actually leverage on technology to fast track this expertise transfer. Training we can't get around. I mean, what I was doing in Minneapolis recently, it's basically going to a center which has a lab and dissecting and honing the craft. Now, this training has to be done in high income centers. However, this is where, looking at, funding and government involvement would sort of facilitate this part. The other thing was the long term should really focus on social advocacy, basically to influence government policies so that we can leverage the kind of exposure that neurosurgeons have, neuro-oncologists have, to basically have country-to-country agreements that enable more people to be trained. And then also to leverage on the fact that, LMICs offer a very attractive setting for research. We have large treatment-naive populations with comparatively maybe high rates of CNS tumors if we were to take the data properly. Because at the moment, we are not really taking as much data from LMICs as we should, because 80% of the research takes place in the high-income countries. So basically, the fact that across board, we have similar issues with getting good brain tumor programs, but the fact that Africa is still quite way behind Asia when it comes to making strides to reverse this trend.
Many of our listeners are American-based neurologists, and I'm curious what you think we as neurologists and then the global community in general of neurologists, neuroscientists, neurosurgeons can do to support neurosurgeons like you and the growing collaborative in Asia and Africa.
I think it's really important to see that in multiple programs and, rich hospitals and rich systems in high-income countries, there's this increasing tendency for global care. And the truth is that the model that this has been based on has been, come on short term, do something, commando and go away. But I think going forward, we should think about more deliberate strategic engagement that allows centers to grow together and to catalyze this growth across continent has become easier. Traveling is easier, webinars and trainings and things can be done virtually, So basically to start these conversations, right, that are learning conversations, it's not just about throwing money at a project, but working with the people who are involved in the project so that there can be learning on both sides. Because truthfully, the world has become smaller and smaller, and COVID taught us something, that anybody can be locked down anywhere, and it's just essential to sort of democratize the access to good health care. The other thing is, in 50 years, it's known that Denmark, for example, will have a median age of 70. The median age in Africa will still be, in the 20s. At the moment, median age in Africa is 18. Right. So the thing is, this place, Africa, is going to be the reservoir for human resource for the future. And the quicker these engagements take place to, provide some quality training for this reservoir, the better the community will be able to, take care of the world's need when it's time for Africa to step up and help. Because, nobody's going to train a 70-year-old medical student.
I wanted to ask you just about your own pathway to becoming a neurosurgeon. And for listeners who are not familiar, how many neurosurgeons are in Ghana, and is there a training program, and how do you become a neurosurgeon in a country without neurosurgeons?
Ghana started its local neurosurgical training in 2000. Before then, neurosurgeons were being trained outside the country. So our first neurosurgeon came to the country in 1967. He was trained in the UK, but basically we had a very barren time between the late 60s to the early 90s where there was no in-country training. Right. Since then, from about the late 90s, we got our first locally trained neurosurgeon. And since then, it's been additional. So we now have 26 neurosurgeons, but that is still grossly inadequate for a country of 33 million people. Right. So we have a training program that is accredited by the West African College of Surgeons. It's a 7-year program. You have to do 3 years of general surgery and then 4 years of neurosurgery, and then you graduate with a thesis at the end. Now, this general surgery plus neurosurgery thing is beginning to evolve, but the key principle for it was that every neurosurgeon would need to have some general surgery capacity, because generally you don't have enough surgeons across board anyway. So having highly specialized neurosurgeons was not going to be really helpful. But, we have now trained quite a number of general surgeons. And this year actually is when we have sort of graduated from the West Africa College of Surgeons being the only accrediting institution. And now we have the Ghana College of Surgeons. So we have a new faculty of neurosurgery in the Ghana College, which allows us now to have a straight 6-year program for neurosurgery without needing to do general surgery. And then you graduate with a thesis. Now, this program, it started this month. We've just taken the residents. So it's a historic batch of residents who are going to start this new program. My own route to become a neurosurgeon was atypical because I have done quite a bit outside the country. So it's been more of a winding road for me than most other neurosurgeons in the country. So I did my first 5 years in Ghana, and then I did 2 years in Israel. I came back to Ghana to write my West African boards, and then have continued working in Ghana since then. I did the traveling fellowship for pediatric neurosurgery in the US under AANS, and built on that, I decided to do a formal pediatric neurosurgery fellowship, which my boss in Miami Children's Hospital, who was my mentor during my traveling fellowship was very kind enough to, recommend me. And I got a place in Liverpool, Alderhay Children's Hospital, where I did my pediatric neurosurgery fellowship. So back in the country, I do general neurosurgery and pediatric neurosurgery. I mean, the key thing is that with so few neurosurgeons, you can't do just pediatric. And so I do all across board. I think that my training in pediatric neurosurgery enables me to be a much better general neurosurgeon. And it also gives me the capacity to give advice to pediatricians and also to fellow neurosurgeons who may not have the scope of knowledge that I would have in it. That's basically my course in becoming a neurosurgeon.
And my last question for you is, do you have any comments on north-south and south-south collaborations? I know you've experienced both. Are they both useful, or some better than others at different stages of training?
I think north-south collaboration is essential because really that is where you get the expertise transfer, and that is where financing makes, sustainable, high-skill neurosurgery possible in our environment. It would be difficult to believe that in Ghana, the first aneurysms to be clipped in the microneurosurgical era were clipped this year, in January of this year. And this only happened because of a north-south collaboration with folks from Washington and then folks from the University of Ghana Medical Center. And I've hosted various groups from the US and then also from Europe, from the Swedish Neurosurgical Society, in doing surgical mission work in our environment. And those are useful. They're important. But it's even more useful to be strategic so that the engagement is not just related around the mission period, but it's also invested into training. And the training being local-based training, because one of the biggest causes of brain drain is fellowship training in the high-income countries. Usually, our neurosurgeons and neuro-oncologists, once they finish a fellowship in the high-income country, will have a job waiting, and the coming back becomes a difficulty because you have to accept low remuneration once you come back. Right. So this local training, local north-south collaborations enable this expertise transfer to happen in the LMIC context, and it enables better retention of this expertise. Now, we should be having much more south-south collaboration, because that's the situation. We just should be having more. What makes south-south collaboration difficult is, first of all, the low numbers of neurosurgeons. So basically, the high clinical load makes it difficult for you to even think about traveling to another country in the sub-region to do things. However, recently we have started discussions where for specialized surgeries like endonasal pituitary excisions, where the expertise is not that, well spread, some of us can go to countries which have neurosurgeons but do not have that expertise to do those surgeries on a mission basis, on a surgical clinic basis, and then come back. Those discussions have started, but it looks like for now it's going to be more north-south collaboration. But the other thing I've put to our collaborators from the high-income countries is also that we create some funding for colleagues from other countries to join us or to team up when the mission is starting, so that, if the mission is in Accra, we can create some funding so that colleagues from Cameroon, Nigeria, and Liberia can come at the same time. And this enables the partnerships that will push South-South collaboration and also basically catalyzes the expertise transfer.
All right. Thank you. This is Teddy Totimeh, and I really enjoyed speaking to you. So thank you so much for your time today.
My sincere pleasure. Thank you for having me.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.